Well, hello everybody, and I hope you're well. I am going to be going over um the latest stuff for CF treatment rather than redoing all the slides. Obviously, most of the stuff has remained the same. But there's every year continued great improvement um on the therapy, and it's very exciting. So to add to that, we have a drug called Alyftrek. I'm not sure how you say it, Alyftrek, that is made by the same company that makes Trikafta, Vertex. So they're not really trying to compete, which is why a lot of the things are the same. This was approved in December of 24, January of 25-ish. It's three drugs again, much like Trikafta. Um, but the wonderful thing about this is that you only have to take it once a day. Um, but it's for all the really the same types of mutations. So there isn't really a huge difference, although there are a few more mutations that can be treated with this drug than is with Trikafta. So once daily versus twice daily. This Vanceftor is a next generation corrector, and there's lots of these in the pipeline. So, and the Dutifticor is replacing the Ivacaftor, and it has a longer half-life because that's the one you have to take twice a day, basically, with Trikafta. It showed that there was really no difference in their lung function with this trial, but the sweat chloride was improved much more. Well, I shouldn't say much more, but was improved more with the new Alyftrek when compared to Trikafta. Same indications, basically. They have the same drug interactions, same side effects, cataracts and LFTs. But you can't interchange this with Trikafta because they're different drugs, obviously. So we'll see. Once daily dosing makes a big difference for a lot of people. So, and the cost is the same. So I'm going to just quickly go through the pros and cons and comparisons here. So once daily versus twice daily, there's superior reduction in the sweat chloride levels with Alyftrek, but it's not that big a deal, and it didn't result in different lung function improvements. Now, we have limited data. This has only been out for a little over a year, so we'll see if that changes, but in the trials, there was really no difference in lung function improvement. There's like 564 variants versus 521 variants. Obviously, for those variants, it's a big deal, but they're I'm sure very rare. The age approval is also important. You can start Trikafta at 2 years old with granules. You have to wait till 6 for this new drug. Like I said, the adverse drug reactions and drug interactions are the same. We just don't have as much long-term information, so maybe this is a little safer or not. We don't know. Patient cost is the same. They're made by the same drug company. When Alyftrek first came out, it was a little more expensive, but then they corrected that so it would be competitive, so people would switch to the new one, I'm sure. Okay, so CF related diabetes. This is becoming more important because the patients are living longer. So patients that, half of the patients were gone by the time they're in their mid-20s and 30s, and now they're living into their 60s and 70s. Who knows? It's probably a normal life expectancy, maybe. I don't know. We don't know yet. But because of that, we're seeing more CF related diabetes. So we have to pay more attention to this. So it affects about 20% of CF patients by the time they're 30. And by 50, it's almost 50%. But it's fundamentally different than type 1 and type 2 diabetes. So you need to understand that. Trikafta has reduced the risk of progression to diabetes and lowers the HbA1c in those who already have CF related diabetes. So some patients have been able to discontinue insulin after starting Trikafta, another joy of Trikafta. But this requires careful monitoring, of course, and we can't assume that it will eliminate the need for insulin. Insulin is still the first line therapy. Metformin and sulfonylureas don't help. It's primarily an insulin deficient, not insulin resistant problem. The GI side effects of oral agents are problematic in CF anyway. Now, early studies have been looking at SGLT2 inhibitors that may be useful in CF. But we're worried, as we would be in anybody, about UTIs, mucus dehydration, which is also already a problem, obviously, in CF. So this is not recommended yet, but we'll see what happens here. We still recommend annual oral glucose tolerance tests for all of our patients from age 10. You can't do just an HbA1c because you might miss some diagnoses. Okay. Another big thing, again, patients are living longer. Mental health has always been an issue for CF patients, but it's recommended to have an annual depression and anxiety screening for all patients. They should be referred, obviously, if they have a positive indication of needing support. Modulator therapy has improved mental health outcomes in many patients. But again, it shouldn't be assumed that they don't need any support. Patients with CFRD, a recent exacerbation or transplant evaluation are at higher risk for mental health, needing mental health support. Telehealth for mental health explicitly endorsed in guidelines to improve access. So some patients they can't get to appointments, and that shouldn't be a reason they don't get help. Also recognize that because of all the CYP3 interactions, we have to be careful with SSRIs. And depression strongly predicts missed airway clearances and inhaled medications. Although, again, with the new drugs, they probably aren't using those as much. I should say my son doesn't, but guidelines now address patient caregiver screening, making sure that parents also are considered for screening. We've also found that avacaftor can affect the mood of a patient. So improvements in mood and energy after starting the modulators has been seen. Possibly a change in the CNS CFTR expression. That's exciting. Another possible benefit. So what's next? Okay, we have this new drug, once daily therapy, which is probably going to be the trend, right? There's also some new novel other correctors that are in phase 2 and 3 trials, aimed at non-delta F508 patients and further improving delta F508 coverage beyond Trikafta. So they're still trying to improve this. There's another drug company other than Vertex getting into the game, and so they've got some very promising agents. The Holy Grail working at base editing and gene therapy is in phase 1 and 2 trials. There's some new gene editing that's very exciting to correct the underlying mutation, which is really exciting. The problem is delivering the good gene to the airway. That's really the issue here. There's also anti-inflammatory targets like interleukin-17 and neutrophil elastase inhibitors that are in preclinical trials to try to help with inflammation. And again, some of the new drugs have been shown to automatically decrease interleukin-17. So these drugs are a miracle. Okay. All right. So what to know? We have this new drug that was once a day, same patients as Trikafta, same CYP3A interaction class. same side effects. The earlier you can start these in these kids, the better. And Trikafta is available from age 2 in granules. So it should be started right away in 2-year-olds. Once they turn 6, you may want to consider changing to the once a day. Treating before lung damage occurs is key here. The modulators lower your CF related diabetes, but don't eliminate it. So insulin is still the first line agents. SGLT2s are investigational only. Stay tuned for that. And HbA1c alone is insufficient for screening for diabetes. Make sure we're thinking about our mental health. Make sure you think about drug interactions if they are added. And probably the thing to look at is once daily therapy is going to be becoming the new standard. So yay, all good news. Thank you. We're going to be taking care of these patients well into older age now, so we have to stay on it. All right, thanks so much.